or in case you want to go ahead and share it with colleagues that you might be working with. We want to make sure that we have it recorded so that you can kind of revisit it and also share it as well. So again, this is done through the Hands United program with the Commission, which is the Capacity Building Assistance Program here. We mainly support community-based organizations around the efforts of high-impact testing, prevention with positives, and organizational management and development. So anything that you might seek help, you might want to seek help with or support in those areas, we're more than willing and able and here to support anyone in those efforts. So we're going to go ahead and get started with the first section, which is on understanding targeted HIV testing, right? Oftentimes we've come from a field or this mentality back in the day where we really pushed for everyone to get tested and anyone to get tested, right? And we realized that the reality of the field and the work that we do is that there's certain populations that are more at risk or more impacted by HIV than others, right? Which is why there's now this duality of the way in which we approach testing, right? We have this approach of routine HIV testing, and then we have something that a lot of us are doing now, which is the targeted HIV testing approach. And in the routine HIV testing sense, what's kind of pushed here is the idea that anyone in the clinical setting should be getting tested, right, or offered an HIV test, no matter what your risk factors are. Anyone between the ages of 15 to 64 should be getting tested for HIV as part of the regular medical care, right? So this idea that anyone and everyone, no matter what your risk factors are, should be getting tested, that's really a routine testing approach, right? It will test anybody, and it's generally done in clinical settings, right? And of course, many of us know that a lot of the people that we interact with on a regular basis when it comes to HIV and risk, they might not necessarily seek regular medical care, so they wouldn't be captured under this umbrella of routine testing, which is kind of where we come in, right? We understand that oftentimes the populations that we work with are very high risk. They might fall through the cracks as far as HIV testing goes in regular medical settings. So we're kind of funded and tasked with this role of making sure that we try to identify them, provide them with support, and helping them realize the benefits of getting tested, right? So oftentimes in targeted testing, it might take place in one of two ways. One might be that the provider initiates it, so it could be that you're interacting with the client and you're saying, hey, based on what you're telling me and what the type of risks that you're involved in, I'd want to recommend you get tested for HIV, right? Or it could be that the patient, the client themselves kind of, they've assessed their risk and says, based on what I know, I think I might be at risk for HIV, so I want to get tested, right? Versus in routine testing, the idea is that, again, we're trying to test anyone and everyone that we might interact with for HIV testing, right? So, and to kind of tie into this idea of targeted HIV testing, a lot of us are being funded to do targeted testing, and the way it's being measured is that they'll give us this number of saying, you're tasked with testing 500 people, right, with a 2% seropositivity rate. This idea of seropositivity rate has come up mainly because oftentimes what was happening was that organizations were being funded to do targeted testing, but again, they were doing more of the routine testing where they would just test anyone and everyone. So that we weren't seeing people that were at risk of being HIV positive actually be coming out positive because we weren't finding those people that were at risk. So we were just testing anyone and everyone. So another way to kind of look at this idea, this trending topic of seropositivity rate, for those of us that aren't familiar with what a seropositivity rate is that, we'll be asked to test a minimum or a max of 500 people. Of those, we would have to find 10 people that are positive to get around a 2% seropositivity rate. So that means 50 tests to find one positive, right? And from a resource perspective, we want to see that seropositivity rate be as high as possible because it lets us know that we're really maximizing resources and really testing people that we consider to be high risk, right? That's the whole reason why we have this idea of seropositivity rate, is we want to make sure that we're maximizing resources and really testing people that are high risk rather than just testing anyone and everyone that comes into the door. So what I want to ask you all, and I know I asked this question during the registration, is what challenges have you encountered in doing targeted HIV testing? And you're more than welcome to kind of chime in and offer your challenges now. And I can start with one. Oftentimes when we're doing targeted testing, we end up finding that we're going to the same locations to test over and over again. Has anyone kind of experienced that? That we find ourselves kind of going? I see Hector raise his hand. Thanks, Hector. That's one of the challenges you might be encountering when it comes to targeted testing, is that we find ourselves going to the same locations, kind of depleting that as a resource and saturating testing in these settings, right? Another thing we might encounter is that we end up going to outreach is similar and only on the basis of overarching MSM, so we might be targeting a very general population and having messages that don't really resonate with people altogether, right? And it might be that a lot of us are funded to work with very similar populations, so we end up finding that we're interacting with each other as our service providers in the same settings over and over again, right? So again, there's a lot of challenges that we might be encountering when it comes to targeted testing that we want to try to kind of delve into and discuss in more detail through this webinar and also during the face-to-face meeting. So now I'm kind of here at the first polling question, right? The first poll. And the question here I have for you is a true or false question. And the question is, positivity rate is generally higher when it comes to routine testing than targeted testing. Is this true, false, or do you think they're about the same? So do you think it's seropositivity or positivity rate is the same in routine testing, or is it higher in routine testing than targeted testing? So go ahead and give us what you think the answer is. Positivity rate is generally higher in routine testing than targeted testing. True or false? Or do you think they're about the same? The positivity rate is generally higher with routine testing than targeted testing. Which do you think it is?
Cool. Yeah.
We have about 8 people that responded so far. You can go ahead and... so this is what we have. Most people have answered correctly. So about 75% of the people on the webinar with us have said that they think that's false, which is true. It is false. Again, routine testing, the premise of routine testing, you want to test everyone and anyone. This idea of targeted testing is really more important only when it really comes to targeted testing, because you want to make sure that that positivity rate is as high as possible. And the concept of routine testing, we don't really, again, the idea is we want to test anyone and everyone, rather than this idea of targeted testing where we care more about making sure that we find as many positives as possible. So with that said, another question around this idea of positivity rates or routine testing versus targeted testing. Do you feel that targeted testing or routine testing is more important? Or do you think they're both important? What's kind of your idea? Do you think that routine testing is more important? Do you feel that targeted testing is more important? Or do you think that they're both important?
I think it's a both.
Yeah.
Oh, good. I hear dialogue right now. So go ahead and answer the poll, and then we'll go ahead and open the lines for discussion in case people want to discuss this in more detail. So again, this is great. Most people are responding and saying that they feel that they're both important, right? So someone that said that they feel that they're both important, can you kind of give us your why you believe that? So again, the lines are currently unmuted, so you can try to give us your insight as to why you think that's the case. And I'm very comfortable with awkward silence. Anyone that answered, there were 7 people that responded and said they believe that they're both important. Why do you think that is?
I feel like because if you only focus on, hi, I'm Stacy, by the way. If you only focus on targeted testing, you might miss those few that really need to be tested that fall into the that won't fall into the high risk categories.
Huh?
And so I find that it's both important to test targeted and routine testing.
Yeah, definitely. And again, that's exactly the point, is that they both have very different and distinct objectives. Generally, when this idea of we want to normalize testing and make sure that everyone kind of gets tested, that's more of a routine testing approach, right? This idea of targeted testing is we understand that certain people need more support than others, right? And that's this idea of targeted testing, right? So again, it's not that one is more important than the other, it's that they both have very distinct and important roles to ensure that people know what their status is, right? So they're both equally as important as far as us reaching the numbers and kind of seeing an end to the epidemic that we kind of know. Does anyone else have any comments or feedback as far as they think that they're both as equally important? Or maybe you want to, negate that. Cool. You guys are making this a lot easier for me than I thought it would be. Hopefully it's clear. And again, if it's not clear, don't hesitate to stop me. I am a Latino, so I tend to speak very quickly. And if you want to say, yo, Tony, hold your horses, please tell me so, and I will. All right? But otherwise, I'm going to assume you get it, and I'm going to keep going. So the next section that we're going to kind of delve into, now that we kind of understood the difference between targeted testing and HIV and routine testing, and kind of understand they're both as equally important to kind of us reaching some of the goals that we have outlined in the strategy, is that we want to kind of understand where does HIV targeted testing really fall into place when it comes to the strategy. So in doing so, I want to kind of take a step back and really understand what the strategy is. This might fall onto deaf ears because you might have heard this a million times over again, but I really want to approach this from an HIV testing lens so that we can kind of relate this to some of the work that we do around HIV testing. So the strategy in itself, we updated it from the end of 2010 to 2015 because there have been major changes since those 5 years when the first national HIV/AIDS strategy came into play. Right? Since then, there have been these huge 5 major changes since 2010 to do around, now we have PrEP, which was, we've always had this idea of post-exposure prophylaxis or PrEP, but now it's very widely accepted and we're really pushing it for certain populations more than others. This idea of treatment and prevention has become more widely accepted. The Affordable Care Act was a major player around how we're doing the work that we do now. HIV testing and treatment are recommended for certain populations around, again, routine testing, 15 to 65. So again, there's been major changes in the work that we do that have really now guided a need for us to update the strategy, as well as markers that have changed too, right? Because there was a series of goals and indicators that we were measuring, and since the initiation of the first strategy, there have been major successes, or in some cases not so major successes, that kind of help us then refocus where we need to do better, right? So with that said, I want to ask everyone a question around the National HIV strategy, right? So the strategy has steps, right? So how many steps are in the updated 2020 strategy? Are there 4 steps, 10 steps, or are there 11 indicators? And give it your best guess. Do you think there's 4 steps, 10 steps, or 11 indicators? The updated 2020 strategy have 4 steps, 10 steps, or 11 indicators.
Why do I not even know what they're talking about? What is it?
And give it your best guess. It's okay. And I hear dialogue, which I love. So keep that going. You're more than welcome to kind of dialogue with each other and kind of try to figure this out. So we have about the majority of you all got it right. There's for those of you that are thinking 4, you're thinking 4 goals. There's 4 goals and there's 10 indicators. So this is a bit of a trick question. And again, the reason why this might be difficult for us to answer is because it's a very layered strategy. I'm gonna keep saying this in a minute, and you kind of understand why, right? There's definitely 4, and you're thinking 4 because the strategy itself has 4 different goals, right? So the first goal was reduce new HIV infections. The second one was increasing access to care and improve health outcomes for people living with HIV. The third one is reducing HIV-related disparities and health inequalities. And the last one, the fourth one, being achieving a more coordinated national response to the HIV epidemic, right? So the reason why this is so layered is because there's 4 goals, and each goal has a series of steps, right, on how that goal is going to be met, right? Where's my little, here we go. So each one of those 4 goals has a series of steps on how that's going to be done. And each step has a series of action or policy items on how that can further be detailed and how that's actualized, right? So aside from each goal having a series of steps and each step having a series of action and policy items, the way in which we measure whether we're meeting the goal outlined is by a series of indicators. And this is where we start seeing metrics, right? This is where we start seeing how are we actually going to tangibly measure, using numbers, whether we're meeting this goal, right? So we have indicators which measure the success of that goal or maybe the non-success of that goal. Each goal has a series of steps on how it's being done. And then each step has action items under it on how it's going to be actually taken into action. Actually taken into action. So the way in which you kind of can see this now is that the first goal has, these 3 sub-steps. So step 1A, step 1B, step 1C, right? So you can kind of see the first goal was reduce new HIV infections. That's going to be done through intensify HIV prevention efforts and communities where HIV is most heavily concentrated. And how that's being then done in more detail is, allocate public funding consistent with the geographic distribution of the epidemic, focus on high-risk populations, maintain HIV prevention efforts in populations at high risk for new HIV risk, but that have a low national burden of HIV. So again, you can start seeing how each goal has a series of steps, and each step has a layered way in which we're going to do those through action items. And then again, like I said a minute ago, the strategy itself has indicators. And think about these as the way in which we're measuring success or not success at meeting that goal. So the entire strategy has a total of 10 indicators on how we're measuring the success of the strategy. And the way in which each goal has, and this is where it's different, right? Because now you start seeing that the indicators actually overlap and they can fall under multiple goals, right? So in some cases you might see that indicator 3 might show up on goal 1 and also goal 3, right? And again, because again, all those goals and pieces overlap with one another. And the way in which the success of one is contingent on the success of another. Right? So the way you can look at this is the first one where it really focuses and directly speaks about HIV testing is really with goal 1, even though again it's sprinkled throughout the entire strategy under different goals, is that reducing new HIV infections, and the way we're measuring it is through these 3 indicators, right? So, and we're expecting to see an increase in the percentage of people living with HIV who know their serostatus to at least 90%. Indicator 2 would be reduce the number of new diagnoses by at least 25%. And we're then going to reduce the percentage of young gay and bisexual men who have engaged in HIV risk behaviors by at least 10%. So again, we have very tangible metrics as to how we're going to measure the success or not success of reaching this particular goal. And this idea of reaching this 90%, that number hasn't changed since the first strategy, right? So if you look at the initial strategy of 2010 to 2015, that number is exactly the same. So, and that's what I put in the box here, and I'm going to make it larger now so you can kind of read it a little more clearly. In 2010 to 2015, what we saw the indicator be was we want that indicator read as follows: increase from 79% to 90% the percentage of people living with HIV who know their serostatus. And the way we updated it, we kind of knocked out that 79%, and now all we're saying is increase the percentage of people living with HIV who know their serostatus by at least 90%. So we still have the same indicator for HIV testing from 79 to 90, which is what it was initially, to now we're just saying we still want to reach that 90%. We still haven't gotten there, right? And this is kind of where we start seeing the cascade, this infamous cascade or Gardner's cascade, right? The continuum of care, whatever you want to call it, that's really revolutionized the way that we do our work. Is again, we saw in 2009 about 85% of the people living with HIV knew their serostatus, so knew they were positive. And you can start seeing that kind of progressively change. So we're still short of 90% since 2012 when it was measured last. We kind of have this continuum of care measured. It was 87.2, so we're about 3% short of what we want to see by the end of 2020. We actually, we're 3% short of what we wanted to see at 2015. So we still keep that same metric in mind. And there's this anomaly that kind of, if you really look at it in a little more depth, part of what we're trying to do here is we want to make sure that we decrease the number of people that become infected, but we also want to get people to know their status. So those two things are tied in together. So what you're going to see happen is that one's going to go up when we want it to go down, and one of them is going to go down when we want it to go up. And that's kind of expected, just because, in order for us to really find new positives, people need to get diagnosed. So we're going to see the number of new people becoming diagnosed kind of go up when we want to really see it go down. But the strategy kind of accounts for that already. So this idea of like new diagnosis and new infection, and some of you guys might have heard of when we're looking at surveillance data, this idea of incidence is something that you might be heard of or kind of have found when looking at surveillance data. What I want to make sure that we're clear on, because it really kind of helps put this idea of targeted testing in a little bit more perspective, is that when we're looking at surveillance data, what we're going to see more and more of is we're going to see things that say new diagnosis, which is different from new infections, right? So this idea of new diagnosis and incidence is going to be made more clear by this statement here, right? So HIV incidence refers to persons newly infected with HIV, whereas individuals newly diagnosed with HIV may have been infected years before being diagnosed. So let me read this one more time, all right? So, because again, usually we see incidence, which is very different from new diagnosis, right? HIV incidence refers to persons newly infected with HIV, whereas individuals newly diagnosed with HIV may have been infected years before diagnosed. Why is this distinction different or important? Why do you think I'm making this point? This idea of newly diagnosed versus incidence data. Care to give it a shot?
The treatment would be different.
How so?
The newly diagnosed person would have more treatment options, rather the person that has had HIV for a while might only have a couple of options.
That's a good shot at it, and I'll commend you for trying to give it a shot. That's great. But that's not quite the point I'm trying to make here. The point I'm trying to make here, and I think, who is this again? Thank you for that.
Hector?
Hector? Thank you, Hector. I thought it was you. When we're looking at, oftentimes when we're told, figure out who your target population is, we're asked to look at surveillance data. And surveillance data is key, it's important, it's useful, but when we're looking at data, oftentimes what we see is newly diagnosed, right? And when we're looking at targeted testing, we're being asked to find people that are becoming infected now, right? Who's most at risk, right? And right now you could find someone and they might have been infected, we don't know when. It could have been 10 years ago, 15 years ago. So at that time, they were part of a population that was very high risk, but they didn't know their status until now, right? So that person could have been infected 10 years ago. Well, we no longer consider them high risk, right? So this idea of incidence, new infections, and new diagnosis is very important when it comes to targeted testing, because one really helps us figure out who exactly we should be targeting, and newly diagnosed data is more about who are we finding out is becoming positive, right? Or who's getting the test result that's positive, right? So what I want to ask now, and this might kind of help us understand this a little bit better as how it relates to targeted testing, is I have another poll question here. To help us decide who we should target for testing, which gives us more of a real-time picture of who is becoming infected recently? Is it incidence data or new infection data, or is it newly diagnosed data? So which one do you think is giving us more of a real-time picture of who's becoming infected recently? Awesome. All right, so the majority of people are getting it right? What's giving us a real-time picture of who's becoming infected now is incidence data, or what we also call newly infected data. That's giving us a snapshot of what population or what people are actually becoming infected now. And those are the people we should be targeting for HIV testing, right? But then if you think about it, like I said a minute ago, most of the surveillance data we're looking at now is giving us newly diagnosed data. It's telling us who are we finding out is becoming, who's getting a positive test result right now, right? So there's only so much limitation that data has. Luckily, some jurisdictions, some locations spend that extra effort in finding out whether the person that just got that positive test result has been infected recently, because that then informs, that incidence data that's going to be useful when it comes to targeted testing. So I'm going to ask a question that as it relates to the National HIV strategy, right? So which does the updated 2020 National HIV/AIDS strategy use for its indicators? Do you think it uses incidence data to measure the successes, or do you think it uses newly diagnosed, or do you think it uses both? Does the updated 2020 National HIV strategy use incidence data as an indicator, newly diagnosed data as an indicator, or do you think it uses both? So we have about 6 people that have answered, 10 people that have answered so far. So the majority of people on the webinar with us today or now believe that it uses both. Actually, it doesn't use both. The National HIV/AIDS strategy only uses newly diagnosed data. So it completely, the first strategy did use incidence data to some degree to kind of measure the success, and that produced some challenges. Right now, as it stands, the National HIV/AIDS strategy only uses newly diagnosed data in its indicators to measure success, which is a little counterintuitive, right? Because if you're trying to reach people that are most at risk at this moment, you would think that you'd want to use incidence data, which you would. But because there are so many challenges with collecting incidence data at a national scale, it was almost impossible to do that. So why are we using diagnosis data versus incidence data as a marker of progress if incidence data gives us more of a real-time picture of who's becoming infected or who is most at need, right? And the reason is that diagnosis data is routine published. It's more routinely published, right? So most states and localities are asked to produce diagnosis data where in some cases they're not asked to produce incidence data. So everyone has to provide how many people, they tested positive. And a lot of places aren't being asked to report on whether that person was newly infected or they've been infected 10 years ago and they're now just finding out they're positive now, right? So it's more routine published. Diagnosis data is more standard across different states, so it's easier to kind of put them together at a national scale. And diagnosis data is available for all states. So again, it's easier to collect diagnosis data, finding out, okay, how many people actually tested positive, than it is to find out whether that person was infected, this past year, or whether that person became infected 10 years ago, but is just now becoming aware of their status, right? So that's the reason why the National HIV/AIDS strategy really focuses on incidence data, even though it's very useful if at any place you come across incidence data to look at that, because it really informs who you should be targeting now, because it lets you know who is the most at risk as far as who's becoming infected now. And the example that I kind of might make this a little easier to kind of comprehend is how many of you guys, and you can raise your hand on the web platform, remember hearing about that thing that happened in Indiana? Does anyone remember that? You can raise your hand. That thing that happened in Austin, Indiana. I see Tracy raise her hand. Hector raised his hand. So this story really came up around this past year, maybe was it a year and a half ago? Within the last year, this idea there's this big surge of people testing positive in Indiana, and they were recently becoming infected, right? And because they were able to trace that it was newly infected, they were able to hone in on where they should target their efforts and who's actually becoming infected. And it ended up being it was IDU, right? IDU users, intravenous drug users. So because of that, they were able to hone in and really tackle, as far as a subpopulation, where that incidence is coming from, where those diagnoses are coming from, and then really target that particular population to figure out where this was coming from. So think about it that way, right? Versus if they're kind of putting everyone in that pool, understanding acute infection would really not be as useful than if you would have looked at it that way. So let's say you're looking at diagnosis data and figuring out, okay, how many people were diagnosed HIV positive in the last year? And you see a decrease, right? So let's say you see a decrease in diagnosis among a particular population. A couple of things could be happening. Oftentimes when we see a decrease in diagnosis, from our side, we think it's because people aren't becoming infected. So we reach people, we say people, why can't you find more positives? Oftentimes most people will say it's because no one's becoming infected. When in reality it could be several things that are going on, right? When we don't see a decrease when we see a decrease in diagnosis data, it could be that there's a decrease in the number of tests being done. It could be that there's a test being performed on people who are low risk. so we're not finding new positives. Or it could actually be that there's an indication that that new infections are decreasing altogether. But it's not always one, right? So think about it that way. When we're looking at diagnosis and we're saying, hey, we can't find new people that are positive, we can't diagnose new positives, it could be generally one of these three things that might overlap and cause that. It could be a decrease in the number of tests that you're doing. It could be the tests are being performed on people that are not high risk. Or it could be that there's actually an indication that people aren't becoming newly infected in that particular subpopulation, which could very well be the case, right? There's things like PrEP now, or maybe there was a campaign locally that really heightened the use of condoms, right? Or a series of those overlapping things can really influence the reduction of new infections. But it's not always that there's no people becoming infected. Oftentimes, more than not, what we've encountered based on our experience with working with different locations and different organizations is that a lot of organizations have a difficult time really identifying what high risk means. We oftentimes hear these key things at a national level of who's high risk and who's not, and that's not always the case. So I think that's very different. Risk isn't constant. Risk changes over time, and it changes across populations, and it changes across locations. So it's important to kind of look at incidence, understand what newly diagnosed means, understand how newly infected, what new infections mean, and how that informs the work that we do. So again, if you're feeling a bit overwhelmed as far as how those two things go, that's okay, because this is just an introduction to those topics that we'll be having during the face-to-face meeting to really help you do the work that you do. And with that said, I'm going to pass it on to Eric, who will be talking about national and Los Angeles-based HIV surveillance data, just to kind of give you more of an idea of what's going on as far as numbers go.
Thank you. So as we've been discussing about the national HIV AIDS strategy, we know that this is a national strategy, and this is a big nation. And so not everywhere and not everybody is impacted with HIV equally. So the national HIV AIDS strategy presents us with a lens to be able to help look at this based on the right people, the right places, and the right practices to be able to reach those who are most impacted. We'll start with who are the right people. Who are the right people in Austin, Indiana may not be the same in Hollywood. We have to think about it in terms of who is most impacted, and what we can base this on in this moment is what we were talking about earlier. What we were talking about earlier is diagnosis. This allows us to look at our recent past to find out who we have been diagnosing, even though this does not tell us exactly who is being infected in real time. So if we think about it in terms of who has been diagnosed in Los Angeles County as of recently, and this data comes to us from the Los Angeles County HIV STD programs through the HIV surveillance reports from 2013. We can compare Los Angeles County to the rest of the nation, and we see that there are some differences. We see that when we're looking at gender, and remind you that the way that this is designed is based on the forms that are turned in to the surveillance, to LA County surveillance. And so when we could parse it by male, female, in the U.S., 20% of the cases are diagnosis from females. In Los Angeles County, it's 12%. So we see that males are more impacted in Los Angeles County than even in the rest of the nation. When we think about it in terms of mode of exposure, or how people become infected, we see that the lime green represents men who have sex with men of any identity. When we compare the two, we see that in the U.S., men who have sex with men represent 65% of the diagnosed cases in 2013, where in Los Angeles County, it represents 83%. As we see in the difference between also within heterosexual cases, which is represented in the yellow, there are more cases in the U.S. than proportionately in Los Angeles County. So this starts to give us a little bit of more of a picture as to who is most impacted. And we're thinking about this in terms of targeted testing. We want to be able to reach those who need to be reached more than just blanket testing everyone. So when we break it down by race, we see that of those who were males, and we saw that the vast majority of those who were diagnosed are male, 89% were Black or African American. Now, in Los Angeles County, Blacks or African Americans of any race make up 10% of the population. Therefore, there is a much larger disparity when we think of this in terms of race. Even when we compare it to whites and Hispanics, when we think that Hispanics of any race make up 48% of Los Angeles County as in the year 2013. And we see a very similar disparity with females. So when we start to think in terms of who are the right people, we start to get an idea of who is more impacted than others in the community, and where the efforts need to be focused. So now we've thought about who are the people, where are the places? So I'm going to start really broadly and look at the nation again. And we see that throughout there are some states that are highly impacted. We see that the southern U.S. Is highly impacted based on some of these numbers of newly diagnosed. Now, when we look at California, California is 16.7. But when we parse out Los Angeles County is even more impacted than California as a whole. So when we start to focus more down on where are the right places, we start to look at what Los Angeles County represents in this larger picture. So this data right here brings together cases of chlamydia, gonorrhea, syphilis, and HIV. And when we compare these to the other metropolitan areas, Los Angeles County has the highest rates when we're bringing together all of these indicators that that for the most part have so much in common when it comes to sexual exposure for HIV. So it gives us even more of an idea of who is getting infected and where they're becoming infected. So when we parse it down even further, we look at the service planning areas. And I think many of the folks who are on this call might be in the metro area. And we see that even in the metro area, the numbers of diagnosis have been going down. Now, is this a good thing or not? Or do we not know? What are your thoughts?
I think it could be a good thing because maybe that means that there's no newly diagnosed, but it can also be a bad thing because maybe people are not getting tested or we're not finding those people that are at risk for HIV.
I think that you're making a good point on both fronts. It could be a good thing that there are less people becoming infected, but we don't know that necessarily based on this data because this is HIV diagnosis data, not HIV incidence data. HIV incidence data is what tells us how many people are becoming infected at any given time. So it could potentially be reflective of the incidence, but then it could also be reflective of not being able to find those who are living with virus and have not been diagnosed. And this is where the targeted testing really comes into play when we think about in terms of what are the right practices and how are we able to reach those who traditionally do not want to be reached, but may be living with virus in their system and don't know it because they haven't tested. So we think about this in terms of what other data might exist outside of this surveillance data. What type of data might you be collecting which could help understand those who are in your community, those who you are trying to reach, who may be difficult to reach based on their beliefs, based on stigma, based on values, based on whatever social determinants might have put them at risk or might have them impacted but are not being reached through our particular efforts in this moment. And this is where the right practices come into play, and how targeted testing is intended to allow us to use the right people, the right places, in the right practices in order to reach those who are not being reached now.
Great. So thank you for that, Eric. So I mean, again, so most of the time when we're looking at data, that's usually the first place we go to when it comes to figuring out who we should target, right? We're asked to look at the data, look at the numbers. But there's a lot of things, like Eric just mentioned, that the data doesn't tell us, right? That data oftentimes doesn't tell us the type of social conditions or belief systems or values that the populations we work with have, right? Which is why it's important for us to kind of understand those things when we're really trying to figure out who we should test, because it lets us know how we're going to engage them, right? So this idea of really targeting a population is what we call in marketing population segmentation, which is where you kind of focus and say, okay, I have an idea that I might want to target YMSM of color, but there's more that you need to find out about them to be able to engage them effectively, right? So and the way I'm going to kind of give this as an example is that if you're engaging what we would call a segmentation brainstorming session, which we'll do in person next week, is we would ask, okay, when you think about MSM, what do you think of, right? What is someone that's MSM? What are they really? What can they be, right? So you can start giving us things like their ages, or maybe you can give us their race or ethnic background, or maybe you can give us their sexual practices, or you can break it down by their risk behaviors. Uses a condom, doesn't use a condom, or things about their identity, right? It could be things or beliefs. Thinks that HIV is only for gays, right? So all these ideas really help us understand how we're going to engage and target the people that we've defined as high risk or target population, right? But oftentimes what we're doing when we do this is we put YMSM of color in this one big category, and we think that we're going to engage in the same way. And I think most of us that have worked in the field for a while, we can see it doesn't always work that way, right? Different subpopulations, even though they'll fit into this category of YMSM, the way in which you target them is going to be very different. So the example I'm going to give you here is that after doing what we would call a segmentation activity, like, I kind of try to give a quick overview a minute ago, and again, we'll do this in person next week, is you can come up with potentially two very different populations that you would target, right? So the first one could be African American men ages 18 to 24, self-identified gay, have never been tested, engage in protected sex with multiple male partners, and live in South LA, right? Or you could have something that says more like Latino men, ages 21 to 29, not self-identified gay, engage in unprotected sex with a single male partner, and have been tested, Spanish monolingual, and live in East LA. Even though they both fall under this umbrella of YMSM, right, you would target these two populations very differently. And oftentimes what we encounter is that organizations say, we ask them, who's your target population? And they'll say YMSM. And I think that's usually the first error that a lot of organizations are making, is that they're not taking an extra step to really understand who exactly are we targeting, what do they believe, what's actually putting them at risk, what's their environment. And I think those key questions can really help you hone in on the type of marketing you're doing, on the type of engagement you're doing, on the way you're kind of speaking to the population, the way you're going to design your program, because the way in which you engage these two populations here is very different. Very different. And I think once you give these two examples, even though they fall under that same umbrella that we oftentimes are given through our funder, the way in which you would engage them would be very different because they're very different populations, right? I hope that makes sense. And I think one of the key ways that I kind of tend to kind of think about environments and social determinants is through what we call the Lewin's formula, the Lewin's equation. And Lewin was a psychologist by practice, and he developed this equation, right? And it's not an actual mathematical equation, but what he said was, behavior is a function of a person and their environment, right? So behavior is a function of an individual and their environment. And the way we can kind of relate that to HIV testing is that, let's say the behavior is not testing, right? That's the B, the behavior. That has to do with the person's characteristics, whether it's, their race, their age, demographics, and it's also influenced by that particular person's determinants of health, whether it's social, the things that they're socially pressured or believed to do, or the environmental conditions like unemployment, right? High unemployment within a particular population, or living conditions within a particular population, or stigma associated with this particular population. All these potential things, environmental conditions, influence whether someone gets tested or not. So I think oftentimes we just tend to think, this particular population isn't getting tested, or this particular population isn't, it's at high risk, but we're not thinking about the conditions that's causing them not to get tested, that's influencing this belief system or this resistance towards testing. So when we're doing recruitment and trying to engage someone into testing, we really need to identify what's causing this population or this community to not get tested or to have these beliefs or to have these ideals. And once we start knocking these out, you will start seeing that it's going to influence and shift the way in which that population views testing. And that can be done at a community scale or at an individual level or a group level, right? That shift needs to happen in some way or another, which is why in our field we have these kind of buffer services that we know for a fact housing is going to influence someone to be okay in treatment or to feel more comfortable seeking services. We know that someone having a job might, preparing them for empowerment through, job skills is going to increase their efficacy to be retained in treatment or care, right? We understand that certain environmental conditions influence someone's well-being and health. We know this in our field, but I think sometimes we kind of forget about that when it comes to HIV testing. What's actually going on in that person's environment that we can kind of approach that's going to heighten the way in which that particular population views testing. And some quick strategies before we close that I wanted to kind of touch upon. Generally, when it comes to what we're seeing a lot of right now is that most engagement and strategies for recruitment and testing fall under one of these 6 categories. Right? So anything that you're doing now to try to recruit or engage someone for testing, it's going to fall under one of these 6 categories, either street-based or venue-based outreach, internet outreach, internal referrals, external referrals, social networking, or social marketing. And oftentimes as a program, I'm pretty sure more than not, you're doing a couple of different categories when it comes to engagement and recruitment. And again, that's decided based on your organization's capacity and also specifically who you're targeting. The one thing I want to focus on right now is this idea of social networking strategy, and this is something that was pushed by CDC a couple years back, and it's continue to push it. And I try to capture this information in the registration and try to figure out how many organizations or programs are actually using SNS. And this idea of social network strategy, the way in which it works is that you're connecting with high-risk participants and you're asking them, hey, I don't have the connection with your community that you do. You actually have personal connections with people that we're trying to target. So we want to leverage those personal relationships you have and try to help us test your friends, right? So rather than us going out there and doing outreach or identifying what you would call, popular opinion leaders that are part of the community, and we're asking them, hey, bring the people that you actually know to come get tested. It's not people that they're going to become friends with or people they're going to meet. It's people that they already know that exist within their social circle. And we're asking them, come bring those people to get tested. And it creates a snowball effect. And you might think that, we kind of do something like this already, but there's a particular way in which this is done. At a national scale, what we generally see when it comes to seropositivity is we see a 1 or 2% seropositivity rate. For organizations that have done social network strategy the way it was outlined, that seropositivity rate tends to be at around 6%. So it's 6 times higher than the national average of seropositivity rate. So organizations that have used social network strategy, the way it was outlined and created, has been shown to be very effective. And the example I like to give is that if a complete stranger were to tell you, hey, I went to this restaurant, you should go check it out, you would think this person, you're like, I don't know this person, why would I believe you? Versus if it's a friend that you actually know and trust, and this person told you, hey, I know you, you're going to really like this restaurant that I went to last week. The likelihood of you doing it is greater because you have that personal connection already, right? So think about it that way, that social network strategy really leverages existing relationships versus what most of us tend to do now is we're out there trying to meet people and try to convince them to get tested, where social network strategy tries to leverage existing relationships already. And this graphic here kind of outlines what that looks like, right? You identify what we call a recruiter, and you ask the recruiter, hey, bring people you know already to come get tested. And then those people that they actually bring in eventually can become recruiters themselves, and then they bring their friends. And then other people that come in can then also become recruiters. And every one of those red dots is someone that's positive, that was diagnosed positive. And one of the benefits of this is it's a snowballing effect that ends up building upon itself, because then you start seeing that the people that came in for testing themselves end up being recruiters. So it really diminishes the amount of work that you're doing out there on the street trying to find people to get tested, because most of the people that are coming in to get tested are being channeled through your program from these recruiters that you identified, where they're bringing in their friends for testing. And again, this is something we'll talk about in a little more detail during the face-to-face meeting. We just want to make sure that you're aware of them, if you haven't heard about it before. And another thing that's happening a lot in our field, which is a little more controversial, is this idea of risk screening, which is a little different from a risk assessment. Usually when we do a risk assessment now, what you might encounter that you're doing within your program is that you do the test, and while the test, if it's one of those 20-minute tests, is prepping, you would do a risk screening to figure out what put that person at risk, right? What's different in the screening tool in this process is that before you even give someone a test, you're doing this form here. So you're kind of trying to figure out whether that person's even at risk of HIV before you even test them. And then let's say you fill out this form and you figure out this person isn't showing me any type of risk factors that put them at risk. Why would I then use a resource to test this person when this person's might have never been exposed or at risk for HIV? Which is again a little controversial, because then you're now deciding who you should test and who you shouldn't in real time. So organizations that do this, they tend to have very strict parameters in saying that we're only going to test people that are high risk, and we define high risk by the person's MSM and they've engaged in unprotected sex within the last 3 months, or they might have never been tested, or they fit within this particular risk behavior before they even offer the test, right? So in this case, it could very well be that, hey, you did the risk screening with them, and you then would tell the person, based on what you're telling me, you haven't engaged in any risk behavior, you're not at risk for HIV, so I'm not going to give you the test. But I can provide you with resources to make sure that you can become more aware of what puts you at risk. Or if you really want to get tested, I can refer you to another program that does routine testing and will test anyone and everyone, right? So this idea of a risk screening tool is different from a risk assessment in that you're kind of doing this before you even to determine whether you're going to test them or not. So those are two concepts that I kind of want to bring up that are kind of happening right now. This one's, again, pretty controversial. In situations in which organizations have done this and done it correctly, it's worked well because it's really helped them identify who is high risk rather than just testing anyone and everyone that comes in for testing. So again, I'm gonna welcome a discussion around this during the face-to-face meeting. And we purposely wanted to somewhat overwhelm you doing this webinar because we figure if you have a lot of questions about these topics that we're covering now, it's going to make our discussion and interaction in the face-to-face meetings that much more fruitful. But it's giving us a leg up on where we want to get started as far as discussions go. So again, the two components, the webinar here and the face-to-face meeting, do build up on each other because I feel like they're going to give you an enhanced ability to kind of have a higher level discussion around some of the things we'll be talking about during the meeting. So again, to kind of review what we talked about today, we reviewed and had a clear understanding of how the updated 2020 strategy informs targeted testing. We reviewed current national and local-based HIV surveillance data. We've explored how to identify local HIV testing barriers using the Lewin's equation, right? To identify, how do we segment, this idea of segmenting and also understanding the environment. And then we examined some of the things that we're using now, some strategies around some of those engagement and recruitment pieces when it comes to HIV testing. And that's pretty much as much as we had lined up for discussion. What I want to do now before we close is I want to make sure that we have the lines available for any comments or questions. And if you don't have any comments or questions, we have an entire day on Monday where we're going to be talking about this a little more in depth, and it really approached this with a very hands-on approach as far as how does this actually happen? How do we operationalize some of these things that we're talking about so that we can start integrating them into the work that you do and enhance your ability to kind of target high-risk populations. Does anyone have any questions or comments about anything we talked about today? Anything at all?
Yeah, okay.
Yeah? I heard a yeah, okay.
Yeah, we're good.
Okay, cool. Anything else? Any questions or comments? It's great to see that we have about 14 people on the line. We started out with about 10. So I'm glad to see that we have about the number we were expecting, around 14 to 15 people now. And again, we're expecting about...
Can we get a copy of the presentation? I'm sorry. Can we get a copy of the presentation?
It's going to be recorded, so I'm going to be sending you guys the link. And I can send you guys also the slides.
Great, thanks.
No problem. Any other comments or feedback?
Thank you, guys.
Even if it's Tony you speak too quickly.
No, but thank you guys a lot. We appreciate it.
Awesome, cool. So we're very excited about seeing you guys next week. Again, if maybe you went to the webinar, you registered only for the webinar but want to go to the face-to-face meeting, we still have about 2 spots left. Or maybe if you're not able to make it, let us know, because then we can kind of open it up for the people that might be on the waiting list. Well, that's that, and we'll be sending up follow-up information about the face-to-face meeting as far as logistics go within the next day or two. But it will be taking place in Commerce at Ultimate's location. So I want to thank them again for offering their space, and we're excited about seeing you guys on Monday.
Yay.
Take care, guys.
Thank you, everybody. Bye-bye.
Tony.
Yeah.
I thought if we were registered for the webinar, we would also be registered for the face-to-face.
Yeah, so if in the registration form, we asked people to tell us whether they were just registering for the webinar, they were just registering for the face-to-face, or they were registering for both. If you can send me an email, I can verify which one you confirmed. And if you want to do both, then I can change it to both.
I think I did put both. I was just making sure because I didn't remember but I think I put both, yeah.
Awesome. Okay, cool.
Okay, see you then.
Bye.
Bye.